For this module, I wanted to discuss procedural coding and billing. And when I initially created this slide and jumped into the documentation and recommendation for procedural um, coding, the main, you really can get into the weeds as far as distinguishing how to code for all of different procedures um, and things. But the main takeaway that that you need to know as the advanced practice clinician is how much clear, succinct, but thorough documentation plays a role in accurate billing and coding for procedures. And what I mean by that is typically when you are in a role of performing procedures, you may not um, be aware of how much your documentation will support whether or not you are reimbursed for all of the procedures that you perform or um, or the supplies required to perform the procedures. So I just want to go into a little bit more detail as to how you can accurately document so that separate procedures will be billed appropriately. So for when discussing separate uh, procedures within the same visit. The first is documenting so that it is understood that there is a separate medically necessary procedure performed. And by that I mean perhaps a patient comes in to discuss cold symptoms or allergic rhinitis, or perhaps a patient comes in for a annual wellness exam, and at that time it's discussed they would also like a joint injection or they need a skin biopsy, etc., etc. Depending on your practice, you can think of several procedures that you perform in the office. And if you have the time and availability and you are able to separate that procedure from the reason for the visit, whether it be a medical, an annual exam or an episodic that is unrelated to the procedure, um, you would code that procedure separately, and then a modifier 25 is added to that code for the procedure to indicate that the procedure is medically necessary and performed separate from the visit. And I want to make the distinction that if a patient comes in with an appointment for a joint injection and you perform the joint injection, clearly that is not a separate procedure from the visit. But if they do come in for that that annual wellness or for a separate E&M visit, and they bring up an additional concern, an additional illness that you can and do address with a procedure, that should be recognized based on the time as well as the supplies required to perform the procedure. So just in your documentation that it is clear and you add that code for the procedure so that the modifier 25 can be added to separate out that procedure from the visit itself. In the Medicare world, this is considered a carve out, where the procedure or separate episodic care is carved out from um, the medical annual visit. So, and I do discuss that separately in Welcome to Medicare and Medicare um, annual preventative visits. Just if you do perform those, you would may benefit from viewing that screen as well. And then in addition to that are repeat procedures. So perhaps you have a patient who comes in with a cardiac history, or for whatever reason you need to obtain an EKG, and the EKG indicates some variance or concern. Perhaps you administer a nitroglycerin, what have you, depending on your practice, what's appropriate and safe. And then you need to see a repeat EKG after an amount of time. Whenever a procedure is repeated because it is necessary and you need to determine if a change has occurred, that needs to be supported in your documentation so that each repeat test or procedure can have that modifier 91 added to the additional procedures to be reimbursed for the time and supplies required. And I just wanted to add the caveat that neither of these two modifiers are used in patient management for inpatient care following a procedure when procedures are considered part of the care related to the initial procedure. So say a patient had um, a um, a total knee and a repeat knee film x-ray was obtained. This isn't going to be carved out or separated because it's necessary based on the plan of care for that patient and the procedure. And then lastly, um, when a patient presents with multiple separate procedures required, there is an additional modifier that can be added to each separate procedure code to reimburse for each individual procedure. And the best way I can describe that is by an example. An example being a patient comes in after a minor trauma to urgent care. Say they have, after x-ray studies confirm they have a fracture that can be reduced manually and then casted. In addition, they have a separate wound that needs to be debrided and cleaned, and then they have another wound that requires suturing. All of these separate but necessary procedures are provided and need to be separately documented and coded for. And your documentation must support all these separate injuries and procedures performed to them in order for the coder to add the correct modifiers to each procedure. And when they are doing that, they are looking at what procedure has the highest RVU value, um, which one is going to be essentially the most complex or have the highest reimbursement value. After that, they will add a modifier 59 to all subsequent procedures um, so that the separate procedures can be reimbursed. And again, this comes down to a couple of things. One, accurate documentation so that your documentation supports these separate but necessary procedures, but also in talking about reimbursement, this isn't so much about reimbursing, charging the patient as it is reimbursing the amount of time, effort, and supplies used in the office or hospital or whatever setting you practice in order to reimburse for how much goes into the care of that patient. So the take-home message for procedural billing and coding truly comes down to, once again, your documentation separating out all these individual procedures that are performed when they are separate from one another and medically necessary, and when they need to be billed accordingly as separate procedures. Um, And the last caveat I wanted to add in regards to repeat procedures, say a patient had an x-ray and the imaging was blurry and you needed to obtain another film, or say a venipuncture sample um, was not adequate or contaminated and you ordered an additional uh, diagnostic. This is a time when that repeat procedure is not billed separately because if a repeat procedure is done outside of the control, or because a sample is bad or a diagnostic imaging um, was not clear enough, that should not be billed separately. And then, in fact, that is just redone based on need, but is not billed out um, to CMS or the insurance company as a separate medically necessary procedure. So hopefully that's a little bit clear as to when to document that it is separate and medically necessary versus perhaps an unclear film or a contaminated sample that then just needs to be redone.